All right, let's jump right in. We're going to talk about managing gastroparesis, and we're going to build a really practical framework using the brand new 2025 AGA guidelines. The goal here is to give you what you need to feel confident handling these, let's be honest, pretty complex cases when you see them in your clinic.
Okay, first up, what are we even talking about? Gastroparesis, at its heart, is simple. The stomach just doesn't empty the way it should. It's too slow. And the real kicker here is that there's no physical blockage causing it. It's not a plumbing problem, it's an electrical one, functionally speaking. And that delay is what's behind those classic, miserable symptoms like nausea and vomiting.
So the definition sounds pretty clear-cut, right? But you know this. Anyone who's taken care of these patients knows the reality on the ground is just so much trickier. The symptoms can look like a dozen other things, the testing can be a minefield, and when you look at our toolbox of FDA-approved treatments, well, it's pretty small.
So here's our game plan. We'll start with the clinical challenge, then get into confirming the diagnosis, look at first-line and second-line treatments, tackle those really tough refractory cases, and wrap up with your key clinical takeaways.
All right, Section 1, the clinical challenge. Let's really dig into what makes this condition so tough, not just for patients, but for us as clinicians trying to figure it out.
So why is this such a headache? Well, first off, the symptoms look a lot like other things, especially functional dyspepsia. So you're already starting off with a diagnostic puzzle. Then, the testing itself can be all over the place, which creates a lot of uncertainty. And here's the big one. We have exactly one FDA-approved treatment, and that's metoclopramide. You put all that together, and it's no wonder this is such a tough nut to crack.
Okay, moving on to confirming the diagnosis. You can see why. With all those challenges, this step is absolutely critical. Everything you do next is built on getting this part right. And thankfully, the guidelines give us a really clear path forward.
So when it comes to the actual test, you've basically got two choices: the 2-hour study or the 4-hour study. Now, the 2-hour test, it's faster, it's more convenient, I get it, it's tempting. But the AGA is really clear on this one. They strongly suggest the 4-hour study is the way to go. It's the standard for a reason.
And this number right here, this tells you exactly why. A 2-hour test has a sensitivity of just 57%. Let that sink in. That means you could miss the diagnosis in almost half of your patients. Half! How can you build a treatment plan on a coin flip? You just can't.
So, how do we get this right? Here are the pro tips. First, make sure you're ruling out other stuff, especially if pain is the main complaint. Then, and this is huge, you've got to control for confounders. That means hitting pause on opioids, GLP-1 agonists, any prokinetics before the test. And when you get the results, make sure it was a direct measurement at 4 hours, not some mathematical guess from an earlier time point. These steps are non-negotiable for an accurate diagnosis.
Okay, Section 3. You've nailed the diagnosis. Now what? Let's talk about our first-line treatment options.
But hold on, before we jump to prescribing, there's some essential groundwork to lay. You absolutely have to optimize blood sugar in your patients with diabetes. You got to comb through their med list and ditch anything that slows emptying. And you need to get them started on dietary changes. We're talking small, low-fat, low-residue meals. Think of this as building the foundation before you put up the walls.
So our first go-to is metoclopramide. As we said, it's the only one that's FDA approved, and it can be really good for nausea and vomiting. Now, we have to talk about the elephant in the room, that black box warning for tardive dyskinesia. It sounds scary, and you have to discuss it, but the key is to put it in perspective for your patient. The absolute risk is actually quite low, and you can lower it even more by starting with a low dose, like 5 milligrams before meals, and even thinking about drug holidays to give their system a break.
Okay, your other first-line option is erythromycin. Now, it's a powerful prokinetic. It really gets the stomach moving. But it has a major Achilles heel, tachyphylaxis. Basically, the body gets used to it and it stops working as well over time. That's why, just like with metoclopramide, drug holidays are a really slick move. Using it for a few weeks on, then a week off can help keep it effective. And, of course, you've got to keep an eye out for things like QT prolongation and drug interactions.
Right, on to Section 4. So what do you do when those first-line agents just don't cut it, or your patient can't tolerate them? There are other options, but, and this is a big but, the guidelines suggest against using them right out of the gate.
This is where clinical nuance really comes in. These drugs aren't off the table completely, but you need the right patient for the right drug.
For example, if a patient got neuro side effects from metoclopramide, domperidone might be a reasonable choice. Got a patient with a lot of abdominal pain, maybe some overlapping IBS? That's when you might think about nortriptyline. The point is, each one has a specific niche, and their use absolutely has to come after a serious shared decision-making conversation.
And I think this quote from the guideline itself just says it all. It really boils down to shared decision-making. If your patient understands the potential risks, but they place a higher value on even a small chance of feeling better, then it might be reasonable to try one of these agents. Not recommended for first line doesn't mean forbidden. It means proceed with caution and proceed together.
Okay, now for the toughest of the tough. Section 5, Managing Refractory Cases. We're talking about the patients who have failed everything you've thrown at them. They've been through it all, and they're still really, really sick.
Now, what does refractory actually mean? It's not just a patient who didn't feel better after a week on one drug. The official definition here is key. They have to have failed at least 2 medical treatments, and that has to include both prokinetics and antiemetics. It's a high bar to clear before we start thinking about more invasive stuff, and that's exactly how it should be.
So before you even consider something like a procedure, you have to call a timeout. There's a mandatory checklist. 1. Reconfirm the diagnosis. Are you absolutely sure this is gastroparesis? 2. Do a deep dive on their nutritional status. And 3. This is not a solo mission. You need to get a multidisciplinary team on board. We're talking GI, dietitians, maybe endocrinology. You have to do this before moving forward.
If you've checked all those boxes, you've got 2 main advanced options on the table: GPOM and GES. And it's so important to know they do totally different things. Think of GPOM as a plumbing fix. It's an endoscopic procedure to cut the pyloric muscle and physically open up the drain of the stomach. GES, or gastric electrical stimulation, is more like an electrical fix. It's an implanted pacemaker for the stomach that's really aimed at helping nausea and vomiting. Different tools for different problems. All right, we've gone from start to finish, so let's wrap this all up and boil it down to the key takeaways you can bring back to your practice tomorrow.
So here it is, your 4-step pathway. Step 1, diagnose it right. Don't skimp. Insist on that 4-hour gastric emptying study. Step 2, start with your first-line players, metoclopramide or erythromycin, but only after you've handled the diet and glycemic control. Step 3, escalate cautiously. Any second-line agent needs a real, in-depth conversation with your patient. And Step 4, reserve the big guns. GPOM and GES are for highly selected, truly refractory patients, and only after your whole team is weighed in.
Look, these guidelines are fantastic. They give us a solid, evidence-based roadmap to follow. But we all know medicine isn't just about following a map. It's also an art. So the final question I'll leave you with is this. As new therapies come down the pike, how are we going to balance the rigor of guidelines like these with the art of truly personalizing care for these complex patients? Because ultimately, that's where the magic happens.